All right, so we're going to get started. People are starting to log on. Tonight's actually going to be a really short night. We probably won't even get a break. I was looking at it. We've only got about 60 slides. We're going over chest injuries, which is pretty focused. There's just a lot going on there. So, we'll talk about everything from superficial injuries that you can see, make it easy. We're also going to talk about some of the injuries below the skin that we worry about, particularly with the heart and lungs, the different types of injuries that we'll come across, things to be able to watch out for because it goes a lot further than just your decap BTLS, for example. So, chest trauma causes more than 700,000 emergency visits and more than 18,000 deaths a year in the United States. Again, remember we are talking about what's underneath the rib cage and everything, not just the superficial damage. Even the ribs themselves can be severe injuries, even if they don't puncture the lung or the heart. So such injuries can involve the heart, the lungs, and the great blood vessels. They may be the result of blunt trauma, penetrating trauma, or both. EMTs must treat any injury that interferes with the body's mechanics of normal breathing without delay. Again, we're talking about during your primary assessment here. Anything that's going to affect your ABCs, that's what we have to deal with. So the stuff that we're going to go over tonight, two things in particular I want you to actually do when you do your A and B. Or at least when you do your B, your breathing, not your airway. But those two things, and we'll talk about it. Those two injuries, we'll talk about it when we get there. Everything else can pretty much stay until you get to your head to toe and then your secondary assessment. But there's those two that I want to see you guys do when you do your assessments at the primary assessment level. Anyway, air may collect in the chest and prevent the lungs from expanding. So a quick anatomy review. Remember the difference between ventilation and oxygenation. Ventilation is the movement of air in and out of the lungs, right? That's the actual physical movement of air. And then oxygenation is the gas exchange that happens both in the lungs and at the cellular level. When we deal with chest injuries, a lot of times it winds up being a ventilation issue that we have to deal with, be it like a punctured lung or even if nothing's been punctured, if we have a lot of swelling, a lot of fluid being dumped into the chest because they took a blunt force injury and there's swelling there, that can make it to where the lung can't expand properly because there's not as much room, those kind of things. So we run into a ventilatory issue. Oxygenation issues can kind of come up whenever we're dealing with the cardiac side of the house, which we'll talk about tonight as well, about what can happen if you puncture a great vein or a great vessel in general. If you hit the heart directly and it bruises up and now it can't beat properly or it fills with fluid and that kind of thing. Those issues can kind of tend to lean more toward the oxygenation side of the house because the air is going in and out of the lungs just fine. But if there's something wrong with the blood flow, then the gas exchange can't happen because the blood's not where it needs to be when the breath happens. The thoracic cage, which is your chest, extends from the lower end of the neck to the diaphragm. All right, it's basically just your rib cage, your sternum, and your spinal cord, or I'm sorry, spinal column. Those are the bones that protect your thoracic cavity. A penetrating injury to the chest may also penetrate the lung and the diaphragm and injure the liver or stomach. Remember, if it's a low injury, it can go below the diaphragm. So here's a picture. It doesn't show the ribs, but everything from the diaphragm up is protected by your ribs, which is great for blunt force injuries. That's what they're designed for. But penetrating trauma can get between the ribs, and then there's not a lot of space in there for those things to go. If somebody gets shot in the chest, most likely something is going to get punctured, be it the lung, the heart, depending on the trajectory. It can be all of the above. It just hopefully it's not, but I mean that can happen. It could puncture the aorta, and then they bleed out. So small injuries can cause serious harm in somebody's chest. So your thoracic skin, muscle and bones have similarities to skin, muscle, and bones in other regions of the body. It's because it's the same damn thing. Your skin is your skin, your bone is your bone. They're different shapes, but they're the same material. So when you're doing, as far as that area goes, when we get to that part of the lecture tonight, it's decap BTLS, right? Deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, and swelling. You're looking for those things when it comes to the skin, the musculature, and the bones. Where things get a little bit more in depth than that is going to be when we start worrying about those internal organs that can get hit as well. Intercostal muscles, that's a term I need you guys to know what that means. Intercostal means between the ribs. All right, so if you think about a rack of ribs that you eat at a barbecue, it's kind of, we're built the same way. You have your bones that are equidistant apart, and then there's this wall of muscle that connects all of them and kind of creates a barrier between your internal organs and the outside world. Um, this isn't very developed in young children, so when they breathe, it's mostly going to be their diaphragm that moves, which means that you're going to see their belly move. We call children belly breathers, whereas adults, we're a little bit better off. We can control our chest cavity. We can actually expand our chest. So when you're looking at adults, you're going to see chest rise. You're looking at children, you're going to see belly rise. Your intercostal muscles are innervated by the spinal nerves, and then your diaphragm is innervated by its own nerve. It's got a phrenic nerve, and that is its sole purpose, is the diaphragm. If anybody gets, and that's one of those, and the phrenic nerve attaches very, very high up in the neck. So that's one of those issues where if somebody gets into an accident, and kind of backing up a couple chapters here, but they get hit in the neck or they get in the head and something gets slipped out of place, they take some damage in their C-spine. If they pinch off that phrenic nerve, the diaphragm shuts down and that's it. There's no more breathing for them. So you'll be bagging them until a neurologist can get in and hopefully fix the nerve, which is going to be a long time, even if you're not far from a hospital. The neurovascular bundle is a network of nerves, arteries, and veins lying closely along the inferior of and slightly posterior to the lower margin of each rib. So remember back when we were talking about, when we were actually in the anatomy chapter and we talked about the shape of the ribs, for human ribs at least, they're shaped like a C, and they're kind of almost like the mouth is open facing down, and all of your vessels, nerves, everything, they run underneath. So keep that in mind. You guys, doing needle decompressions is out of your scope, but if you come to paramedic class with us or anywhere else, you're going to learn how to do that. One of the things that we always do is we find the intercostal space we want and we rock over the rib that we're wanting to go between so that we can dodge any vessels that are underneath it. The pleura covers each of the lungs in the thoracic cavity. Basically, those are moving parts. The lungs expand with every breath, and with that, the chest has to expand as well. So we don't want a lot of friction there. Breathing should be effortless, should be painless, and under normal conditions, it is, because your pleural linings have like a viscous fluid within them, and so everything is very slick. It moves really well, really easily, and as long as you don't have a problem with that stuff drying up, then you're fine. It can, but the problem is if air gets exposed to it, say somebody pops a lung, that can cause some issues. If even if there's like a medical condition, anything that can cause that pleural area to dry up, they get what's called pleurisy, and every time they take a breath, it's like grinding sandpaper along their lungs. It's going to hurt real bad. So your patient, if we can't see that, right? You can't see pleurisy. But if you look at your patient and they're breathing weird, like they're not taking very deep breaths, every time they try to take a deep breath, they wince in pain. That's usually a sign that there's something going wrong with that lining for whatever reason, and it's making it hard for them to take a breath. And with that pain comes rising vital signs. So pain management is important. There's not a lot that we can do as EMTs as far as medicine goes, but we can do patient positioning. There's a lot of things that we can do to kind of help the patient that will do a little bit more for pain relief than just going straight to the fentanyl. The ribs are connected in the back to the vertebrae and in the front to the sternum. So as you can see in this picture, that flat bone on the left, on the anterior side, that's your sternum. On the posterior side, on the right, those are your vertebrae. Each rib connects almost. Their bottom couple of ribs, if you look at the picture on the left, 3 of them, or actually more than that, but a few of them actually combine into one connection. And then you actually have what's called floating ribs. You can't see it in that picture, but you can see it on the right. The very, very bottom ribs don't come all the way around. They're just posterior protection only. It's mostly for your kidneys at that point. That's why they're back there, because your kidneys kind of sit toward the back of you. That's why you feel that flank pain if they ever get hurt. That's the main reason for those. Those don't really do anything for your chest, but they're there. The trachea divides into the left and the right mainstem bronchi. I'm talking about your airway now, which supply air to the lungs. Whoops, hold on. Let me find where I'm at. Okay, we did say that. All right. So your trachea divides off into two. You have your left and your right mainstem bronchi, and then you have your thoracic cage, which is your rib cage. This contains your heart and your great vessels, the aorta, the right and left subclavian arteries, their branches, the vena cava are in there, and then of course your lungs are in there as well. Your lungs and your heart. The mediastinum, if you think about what that is saying, the media being the middle. Mediastinum is a central part of the chest containing the heart, great vessels, esophagus, and trachea. All of those things run down there. So if you get hit hard in the chest, especially in the middle, any one of those organs can be damaged. So somebody gets popped in the neck, they may have a hard time swallowing, they may have a hard time breathing. If they get hit high in the chest, it could be the same thing. Your esophagus is going to go all the way down to your diaphragm. So pretty much the base of your chest is where the diaphragm stops, and then your stomach kind of hangs out right below your diaphragm. So anywhere in that sternal area, you can take damage to what we usually would consider just a throat organ, but it does run pretty deep. The diaphragm is a muscle that separates the thoracic cavity from the abdominal cavity. And just know that that's your primary muscle for breathing. So we want to protect that if at all possible. For your mechanics of ventilation, the intercostal muscles between the ribs contract during inhalation. And what that does is it closes in the ribs on themselves. And because of the way they're anchored, it raises the chest. The diaphragm at the same time contracts down, because it's one of those, like, y'all remember those, I don't know, I'm probably dating myself here, but we used to have these little popper toys when I was little. They were like half circle pieces of rubber that you popped them inside out, set them on a table, and when they snapped back into position, they would shoot up pretty high off the table. You know, simpler times before iPhones and iPads. But your diaphragm kind of works the same way, except it doesn't do the popping thing. So it sits there, it's a concave muscle. Yeah, I don't remember what they were called either. But when the muscle contracts, that bulb kind of that bow pulls down. So your chest is rising, your diaphragm is dropping, and that creates more room inside the chest. So more room without any more air means less pressure. And then atmospheric pressure now has somewhere to go, so it goes into your chest. When you exhale, the diaphragm relaxes, which makes it rise back up into that concave position. Your chest cavity pushes down. Now you've taken X amount of air and you've crammed it in to a smaller place, which raises the pressure and allows you to push that air out of your lungs and back into the atmosphere around you so you can exhale. As long as we stay somewhere with enough pressure outside of us to let that work, then we're fine. Some people at high altitudes run into issues where that doesn't work properly for them. People in airplanes, if you're flying in a pressurized tube at 15,000 feet or whatever, and your cabin depressurizes, now suddenly there's not a lot of pressure around you, so breathing in gets pretty hard to do. That's why if anybody's ever been on a plane, ever worked on like air crew of any sort, the pilots have, well, actually not just the pilots, but any military members, any civilian aircraft members that are actually on the plane at altitude that have a job, they will have a mask. So if anything happens to the pressurization in the cabin, they put the mask on their face, turn their bottle on, and it is actually positive pressure. Instead of them having to suck the air out of the tube like we do as firefighters, it just blows into their face. So it's enough pressure to inflate the lungs. They have to relax to let the air in and then force the air out. It's backwards from how we normally breathe, so it's a little weird. But I mean, it's the only way to get air in if you're at that altitude. So Here on the ground, usually we don't have that problem. But sometimes you may see where a patient is having an issue breathing, and and it could be a pressure issue. Typically, if the diaphragm's not working, or if the if the nerve to the diaphragm is messed up, or the nerves to the intercostal muscles are messed up, if the chest can't expand, then it doesn't allow for that pressure difference. A patient whose spinal cord is injured below the C5, cervical spine number 5, may lose the power to move the intercostal muscles, but at least the diaphragm will still work. The patient will still be able to breathe because of the diaphragm, but it's going to be a hard time breathing. They're not going to be able to get a really good breath because they can't get their chest wall to expand. Patients with a spinal injury at C3 or above can lose the ability to breathe entirely because that's where that's where the phrenic nerve is at C3. And remember, we talked about any injury to the spine, whatever level it's at, everything below it stops. So if your phrenic nerve is at C3, if you injure it there, you've injured the nerve. If you injure it above there, the phrenic nerve is fine, but it can't get the signal from the brain because it's on the other side of the roadblock. Just a real quick recap of minute ventilation or minute volume. This is the amount of air moved through the lungs in 1 minute. So if they're breathing shallow and they're not getting as much of a tidal volume in for each of their breaths, they're going to have to pick up their rate to keep their same minute volume. If they're breathing slowly, then they need to pick up the amount of air they pull for each breath to keep the minute volume. So, I mean, it's not a hard equation. You see how one affects the other is a big thing that I want you to walk away from with this. Patients with decreased tidal volume will have an increased respiratory rate. So if they're not breathing as deep, they should be breathing more often. 1,000 to a 1,500 ml bag BVM might overinflate the lungs. We've talked about that. We'll actually go over that in depth when we get to the boot camp. But typically for an adult, half of your adult BVM bag is all you need. If you're sitting there, or if you see somebody on scene, they're sitting there and they're squeezing that entire BVM bag into somebody's mouth, stop them. Because half that bag's going into their stomach, and you're going to have a bad day. Not to mention, as their gastric inflation increases, it starts to put pressure on the thoracic cavity. The diaphragm no longer has the ability to move down because they've got an overinflated stomach. They're actually going to cause more harm than good. Rapid respirations can cause an acid-base imbalance. Remember, you're breathing in oxygen, but you're also breathing out CO2. And we want to keep that balance there so that we can keep our pH in a good range. If they start breathing too fast, they're going to blow out all their CO2. Then they're going to become alkalotic. So there's 2 types of injuries to the chest, just like anywhere else. You have open and closed. If it's open, that means you have a break in the skin. Closed chest injuries means the skin's not broken, but everything underneath it might be. We don't know. The closed injuries are often caused by blunt trauma, so something large that hit them, not anything pointed that can penetrate. Steering wheels, baseball bats, baseballs. I've responded to people who got hit by a line drive baseball that cracked a rib. It can happen. Drew Brees is out. He's been out for a while because a large lineman just flattened him into the ground. Blunt force trauma broke a bunch of his ribs and punctured one of his lungs. If the heart is damaged, it may not be able to refill with blood. Mainly because think about your heart. It's a muscle, just like any other muscle. If it gets damaged, it's going to swell. If the muscle itself is holding all this fluid to try to repair itself, or if there's a bunch of fluid around the outside of the heart where it doesn't belong, the heart no longer has the ability to contract like it should. So you're not going to get a good heartbeat. If it gets bad enough, this results in cardiogenic shock. Think about, we talked about the different types of shock that were out there, and they're all named after what the cause is. So if it's cardiogenic, that means it's sourcing from the heart for whatever reason. Cardiac arrest is cardiogenic shock. Lung tissue bruising can result in exponential loss of surface area. This leads to decreased oxygen and carbon dioxide exchange. So their carbon dioxide is going to climb up, their oxygen levels are going to fall. They're going to be hypoxic, hypercarbic states. And remember what your first sign of hypoxia is? Anybody remember? Anxiety. Good. Yeah, it's not the blue lips and the fingernails and all that stuff. That's a late sign. The first thing that's going to happen is they're going to start to freak out when they realize that they can't breathe. It's usually an immediate and it's an uncontrolled too. Like they're not just being Karens or anything like that. It's I mean, think about it. If you've ever tried to take a breath and couldn't, the panic sets in almost immediately. In open chest injuries, an object is somehow broken through the skin. It may or may not get past the rib cage. It depends, but it at least made it through the skin. So there's going to be blood loss. There could be some organ damage on the inside. The bones may get hit. They may have gotten hit just perfectly where there's zero damage to the ribs. But if that happens, that means those ribs aren't able to stop whatever it was. The lungs and the heart, the diaphragm, any of that stuff can be damaged. And if it's an impaled object, leave it there. Don't try to remove it, especially if it's a rib. Should probably stay as much on the inside as possible. Just don't try to push it back in either. But the big thing is we don't want to increase their bleeding by trying to remove an object that may be occluding it where it's at. Blunt trauma to the chest may fracture the ribs, the sternum, chest wall, bruise the lungs and heart, can even damage your aorta. And it's not just things hitting you, right? Imagine that if you have a patient that's in a car wreck, the steering wheel doesn't hit the patient hits the steering wheel. They're the ones that are still moving. The steering wheel just stops them. And then everything inside of them, all their organs, continue to move. One of the things about it is that by design, our heart just kind of hangs, right? It's connected at the top. It hangs. All of our great vessels are attached to it and everything, and it can sway. If you get hit hard enough, your heart will definitely move forward or back or whatever. But our vessels are designed not to have too terribly much slack in them. So if the heart gets hit, or if you get hit hard enough that your heart moves enough, it can actually shear off of the vessels, and now you're going to be bleeding out on the inside. So that's one of those secondary injuries that we talk about when we're thinking about our MOI, because we can't see that. When you're looking at your mechanism of injury, consider the fact that those organs could have shifted for a split second in the impact, and it may have caused some real damage to your patient that you can't see. Some signs and symptoms of a chest injury: you have pain at the site. Just like anywhere else, you pain receptors everywhere in your skin and your muscles. So if you get hurt, you're going to know. Pain localized at the site of the injury that is aggravated by or increased with breathing, especially if it's a problem with their lungs. Irritation of or damage to the pleural surfaces will cause that sandpaper feeling when you try to take a breath. So your patient is not going to want to breathe heavy, and that's a problem. As you think back to your minute volume, if they can't get a deep enough breath, they're going to have to breathe more often. And if they breathe more often, they're going to blow their carbon dioxide out. So it's kind of a lose-lose situation no matter what they're looking at. Bruising to the chest wall, crepitus with palpation of the chest. That's if you press on the chest and you hear bone against bone, that usually means that they've broken something, either a rib, could have been one of their vertebrae, depending on where you're pressing. But if you're pressing on the chest, it's going to be their ribs or their sternum. Any penetrating injury, dyspnea, which is trouble breathing. This could be caused by an airway obstruction. It's not necessarily something hitting the chest. It could just be something they got popped in the neck as well, or they were eating something while they were driving down the road, got into an accident, went to scream, and just sucked the piece of steak or whatever it is down. Prompt vigorous support of oxygenation and ventilation with prompt transport is required. If that's what you're looking at, a lot of times you're not going to get out of your primary assessment because you're too busy trying to fix things. So secondary assessment gets kind of tossed to the wayside. It's really, really important that you focus on those areas in the primary, even if no matter how distracting some of the secondary injuries look, always stick to the ABCs first, get them fixed, and then move on. If you can't fix them without, well, let me see how I can say that again. If you can't leave them without them losing their fix, you have to stay there. In other words, like let's say I showed up on an accident scene and I don't have anything with me, no OPA, no NPA, and I've got an unconscious patient on the ground, and he's got injuries out of this world from head to toe. And any one of them could kill him in a little bit. You know, a couple minutes goes by, he's probably going to lose too much blood, but he's not hemorrhaging. He just has some pretty moderate bleeds, but they don't look like they're going to stop anytime soon. But he's also snoring. He's got snoring respirations where his airway is occluded. So I'm going to get there and I'm going to hold his airway open, but I have no devices to make a patent airway. So the minute I let go of his jaw thrust, he loses his airway. If I'm the only one on scene, then that's all I can do. I can't leave it because as soon as I let it go, it falls apart. So when you're doing your assessments, same thing. If you get to A and you have to fix A, you have to give me some kind of way for you to maintain A so that you can move on. Now, in your assessments at the boot camp, the easy way to do that is say, I'm going to have my partner hold the airway open. Perfectly fine. And you've got an imaginary army of people that can help you. So everything that, if you need somebody to stay on it, you can say, I'll have somebody stay on this and I'm going to continue with my assessment. That's perfectly fine. But you have to let me know that you're not just letting go of his airway, letting it fall apart. And if you do forget that, we'll remind you. Like if you open up somebody's airway manually, you forget the OPA or the NPA, and then you go to move on. The minute you let go and you move on, I remember like he just lost his airway. Kind of try to draw you back to it, like, hey, you can't, you got to give me more than that. Give me something that's going to stick. So just keep that in mind. Some other issues, hemoptysis, which is coughing or spitting up blood, especially if they took damage and started bleeding into their trachea or into their throat. Failure of one or both sides of the chest to expand. You're going to see that a lot when you start dealing with really badly broken ribs or popped lung. Typically is what's going to cause that. Rapid, weak pulse and low blood pressure, which is you're basically looking at shock at that point, which in this case, because we're dealing with trauma, a lot of times that's hypovolemic shock. This can result from extensive bleeding of lacerated structures within the chest cavity. That's the kind of symptom you're going to see if they did happen to shear one of the main vessels. It may not be enough for them to just bleed out on you, but if it's bad enough, they're going to start to not be able to transfer oxygen very well because they don't have the blood where it matters. And then cyanosis around the lips or the fingernails, if they're bad off, you'll see that, but you won't see it fast. Patients with chest injuries often have tachypnea, which is rapid respirations, and shallow respirations because it hurts them to take a deep breath. But again, we talked about what that does. So we want to try to get them to take slower, deeper breaths, even though it hurts. And it's our goal at that point, if they're awake to listen to us, and we tell them, all right, we need you to slow your breathing down. For them to comply with that, we have to find a way to lessen their pain, and it may not be within our scope to do so. We can do everything we can as basics, but we need ALS coming, and we're about to get to that because we're getting into our patient assessments. Just like anything, scene size up, BSI, scene safety, first thing you're going to say, and the rest of your assessment and your scene size up, you're just kind of painting a picture. How many patients do you have? Can you do everything you need? Do you need help? Is there any hazmat issues you need to be concerned about? Is there any additional resources you need? This kind of thing. If you have somebody that has a problem with their A or B, airway or breathing, and you can see it from the very beginning, go ahead and call for ALS because they may need a tube, they may need a needle decompression, and there's a lot of stuff that a paramedic can do that you can't. Even though the assessments are the same, the paramedics have a bigger toolbox. Check out your mechanism of injury. Chest injuries are common in motor vehicle crashes, falls, industrial accidents, and assaults. So think about it. Even if everything works right in your vehicle, the seatbelt's going to cause some damage, the airbag's going to cause some damage. Those are usually not bad injuries, but they can do some damage, especially if the person isn't the right size. Let's say that somebody is exceptionally small, like a child in the front seat, when they're too small to be, the seatbelt doesn't fit them properly, they're going to have worse injuries. If it's somebody that's exceptionally large, a lot of times they don't like feeling that restriction of the seatbelt being pulled so tight around them. So people are bad about taking that cross strap and putting it behind them. Sure, you're still anchored to your seat, but you're going to go toward the steering wheel faster than what the safety features were designed to expect. So you might get to the steering wheel before the airbag fully inflates, and then you're going to have worse injuries. Determine your number of patients, consider C-spine. Form your general impression. You know, for medical, it's sick or not sick. For trauma, it's pretty much, are they mangled or not? Does it look like they have any obvious severe injuries? And when it comes to the chest injuries, keep in mind, you know, you might not see the injury. It might just be a little pinpoint hole that you haven't found yet. But if it's something like a gunshot wound, keep that high index of suspicion that if they did get shot in the chest, you may not see it yet, a bullet would have wreaked havoc in that area. So your injuries may wind up being a lot worse on the inside than what they look like on the outside. Perform your physical exam. Obvious injuries, appearance of blood. Do you see any difficulty breathing? Cyanosis if you're a little bit late getting to the scene. Irregular breathing, chest rise and fall on only one side, and accessory muscle use. Look for their JVD. We talked about that a little while back. If there's a damaged area of the heart where the heart's not able to flow blood like it should, then the blood's going to start to back up, right? Because the heart can't move it as fast. So the blood waiting to get in just kind of sits there and waits. Just like any other car accident on the interstate, when the traffic gets backed up, the blood's going to do the same thing. And when it backs up, one of the easiest ways to tell is you look for the jugular veins. They're the ones that run down the neck. They're closest to the heart that you can see. And if they start to back up with blood, they're going to engorge themselves, and you'll be able to tell pretty quick. So that's something that we need to look for. Once you've done that, assess your ABCs, assess overall appearance, and ask how sick is my patient. If they look like they're about to die, or if they look like they, you know, if they're missing body parts, or things aren't moving like they should, things aren't moving where they should be, or things are moving where they should not be, that's a problem. Once you get done with that, we do move into the airway and breathing. So this is where you're going to kind of earn your bread and butter as an EMT for chest injuries, because I don't want you to just go decap BTLS and then move on. There's a couple of other things that we look for. There's a couple of interventions that we do in this area for these two items. Addressing life threats begins with the airway and the breathing, unless life-threatening bleeding is there. So again, you know, hemorrhage first, because the air doesn't matter if you have no blood to transport it. Normal breathing should be effortless, shouldn't be any pain. You shouldn't see any deviation from the pattern that they normally would breathe. Their trachea needs to be straight down the center of their throat, that kind of thing. Consider early cervical spine stabilization with blunt trauma. So if they have and we'll talk about it more later on, but if they have a flail segment or some kind of obvious chest trauma, whatever it was that did that may have caused them to whip their head a little bit, and now you could possibly have C-spine damage. So consider putting the collar on them. If you're going to do that, though, just a word of practical advice: do a real quick scan of the neck before you slap the collar on them, because if you don't, the collar's going to have to come off for you to do that. Yeah, you can always do a real check later on, but just do a quick scan. Like, all right, before I put this collar on them, do I see anything obvious? JVD, tracheal deviation, step offs? No? Okay, cool. Slap the collar on. If the jugular veins are distended, a lot of times that's pressure on the heart. It may be that the heart's just bruised and it's not able to beat properly, but more often than not, from an external chest injury, that is caused because there's a lot of fluid building up around the heart in the pericardial sac. What that does is it starts to constrict down. The heart can't beat properly. It can constrict fine, but when it does, all that fluid stops it from going back to its fully resting position to refill with blood. So the next time it tries to beat, it's only beating with the partial amount. So each beat pushes less blood. And an easy way to tell that is if you take your stethoscope and you listen to their chest, the heart's going to sound like it's underwater. Determine whether the breathing is present or adequate, and inspect for your decap BTLS. Again, we're in the primary assessment. I don't want you guys to do that at this point. So I know it says it on the slide. I guarantee you, if you do decap BTLS in your primary, they're going to fail you. It's still a critical fail on your sheets. So disregard that bottom bullet. You'll get to that part when you do your secondary, but I do want you to look for two injuries, and we'll talk more about them in a little bit. Look for a sucking chest wound and look for a flail segment. when you get to your breathing. So just once you're there, you check, do I have equal rise and fall of the chest? Do I feel air movement? Cool. Cut the shirt, open it up, just do a quick look at the chest. Do I see any holes? Or do I see any like sections of the rib cage that are not moving with the rest of the ribs? If you don't see it, and we'll assume that you don't for now, then great. Go back to the rest of your primary assessment and move on with C. So a sucking chest wound and a flail segment, which is a section of ribs is completely broken off from the rest of the rib cage. And so I'll explain how that looks, what you're looking for when we get to that, because it's coming up pretty soon. All right, for circulation, assess the pulse and determine whether it's present and adequate. Remember, your vital signs are more than just the numbers, so make sure that, yeah, you may feel it as beating at a good pace, but make sure it feels right. If it's really, really thready and hard to find, that's a problem because it means you're not really getting that much blood flow. That's another sign of a tamponade because each beat is not sending the right amount of blood, so it's going to be kind of hard to find it. If the pulse is too fast or too slow, or if the skin is pale, cool, clammy, a lot of times that means your patient's going to be in shock. So we want to immediately address that. Um, address your life-threatening external bleeds immediately, and then make your transport decision. If you have to fix anything at this point, they're a high priority for transport. If they have any kind of altered level of consciousness, they're a high priority for transport. If they, oh, I just, my ankle hurts, and they're in their right mind and you don't see any problems and it was a low speed accident and they, no sign of neck trauma, well, and real world, a lot of times you wind up getting a refusal, but they would be considered a low priority, or at least a stable patient. So you can do your entire assessment on scene. That's okay. But yeah, if there's any problem with their primary, they need to go to the hospital right then and there. For your history taking, this is going to be your sample history, and if they're awake, you can get your OPQRST. Anybody remember what those are? Onset, good. All right. So what caused it? What were you doing when it happened? Provocation, does anything make it worse or better? Quality, describe the pain, and you let the patient use their own words. So, is it sharp pain? Is it diffuse and spread out? Can you easily tell where it's at? Radiation, does the pain spread somewhere? So, like if it's a pain in the chest and they can kind of feel it in their shoulder or down their arm at the same time, that would be the radiation. Severity, there you go. Severity, pain scale, um, 0 to 10. Anything above a 2, just so you guys know, if somebody's going to be honest and accurate, which they never are, but if they're going to be honest and accurate about their pain scale, anything more than a 2 requires some kind of pain management. You shouldn't let somebody get to a 5 or an 8 or anything like that before you start trying to do something. Now, like I said, as EMTs, we can't really give pain meds, but we can help stabilize injuries. Yeah, they're always a 10. Somebody could say that they had some bad Mexican for lunch and their stomach ache is a 10, or 12, or 20, or a death stare, or whatever. But if they're being honest, then a 2, and you can use your own objective look at this too. If you look at them and they look like they're in pain, try to do something for their pain because it's going to help their breathing, which is going to help everything else. If you look at them and they look like they just went for a stroll in the park and they're not, their actions are not matching what they're saying, and they don't look like they're in that much pain, then whatever. You don't have to do something that's not necessary. But if they tell you they're hurting, um, even if it's not necessary, a lot of times it helps them psychologically. So I even if I know it's BS, I'll still go through and help, try to help them a little bit. It shows some compassion. It makes them not think that you don't care. So as long as I'm not skirting the things that do matter, I'm not going to skip somebody's airway and try to go straight to pain relief, that kind of thing. All right. For your physical exam, if it's an isolated injury, you can focus on that injury. In other words, if all they are saying is that their ankle hurts and you don't see any signs of any other damage, you don't have to poke and prod on their head and their chest and all that. Just go straight to the ankle. That's okay. Some of the things you're going to look at, patient's complaint, the body region that's affected. Ensure wounds are identified and bleeding is controlled. Look for the location and the extent of the injury. Somebody may say that their ankle hurts, but when you get down there and take a look, you find out that they broke their leg. That's a little bit different, especially for patients that may have gotten hit in the head. They're going to complain about the worst injury. They're not going to complain about the lesser ones because they probably don't even realize they're there. They're too focused on the one that hurts the worst. Assess all underlying systems in that area. So if it's chest pain, if they got hit in the chest, you're going to assess their breathing. You're going to assess their cardiac function, not just their ribs and skin. Consider the anterior and posterior aspects of the chest wall. So that's the outside and the inside. Changes in the patient's ability to maintain adequate respirations a lot of times is because they're in a lot of pain. So if you look at them and they're struggling to breathe, or they're breathing really fast and shallow, it's a 10. You don't even have to ask them. You can pretty well guarantee if it's not actually a 10, it's pretty high. It's definitely high enough to try to do something about. For significant trauma, likely affecting multiple systems, which is a lot of times the case with chest injuries, start with a rapid physical exam. So remember, they need to go to the hospital. The sooner you can get them in the truck, the better. But before you try to put them on a litter or put them on a stretcher, you want to know what other injuries might be important to you before you roll your patient. So it's a quick head to toe. I'm not worried about the paper cuts. I'm not worried about small broken bones or anything like that. I'm not even worried about gross deformities from the knee down. I'm only concerned about mainly the neck, the spine down the back, the hips, and their upper legs, because the femoral arteries are there. And if they have a broken femur, for example, they could bleed out. Those are my main concerns, because those are the things that as I'm rolling my patient around, trying to get them maneuvered under the truck, I could cause more harm. If it's something to do with the arms, the lower legs, the feet, I'm not so concerned about it. I can address all that in the truck. At this point in your secondary assessment, yes, you are definitely using DCAP BTLS. So from head to toe, or if you are looking at a local injury in the real world, DCAP BTLS only to that area, that's perfectly fine. But this is the point where you're going to do that, because this is the point where it matters. In the primary, I really don't care if they got a contusion. It doesn't matter. That's not part of their ABC. So here's where you'll do it. Get them in the truck and get going. Your vital signs are always going to be the same. Your pulse, respirations, blood pressure, skin condition, pupils for your neuro check, breathing rate. Now in COVID land, they want you to get a temperature as well. So get that. And then reevaluate every 5 minutes or less. If they're really bad off, you don't have to wait 5 minutes. If they're normal or a mild injury, 15 minutes is fine. If any of your vitals are out of whack, say, your breathing and your pulse rate is high, and especially if you have skin condition changes, those are going to be big signs of shock. And when we're dealing with potential problems to the chest, as well as any trauma in general for blood loss, shock is really high up on our radar, because once it starts, we can't stop it. We got to try to stop it from getting bad. Once they get down that road, we can't bring them back. All right. And then we talked about your reassessment. So reevaluate everything you did. If you had to make a change in your primary, make sure that that change is still there. And something that I do, I show up to my patient, I'll do my scene size up. And when I do my primary, that's where if I have any intervention in the primary, fine. Then I do my quick head to toe. Secondary assessment, as they call it in here. I do my quick head to toe, see how I can move my patient, if I can, if there's anything I need to pay attention to. As soon as I get my patient in the truck, before I go back and do the full head to toe or the vital signs or any of that stuff, I go back and I look at my primary. Did I have to put a tourniquet on and then suddenly lose it while I was manipulating my patient? If I had to put a tube down somebody, even the LMAs like what y'all use, if I have to do that, did it come loose while I was moving my patient? Those things matter because those are the life threats. So every time you go to start a new part of your assessment, go back and double check their ABCs to make sure everything is still okay. Then move on. So ABCs, quick head to toe, put them in the truck. ABCs again, head to toe. ABCs again, vital signs. ABCs again, history. Just like that, because the last thing I want to do is lose a tourniquet, go through my entire assessment, and then realize that my patient bled out because I didn't go back and double check that kind of thing. And then, of course, communicate everything to the hospital, especially if you have to make a change and if anything's outside of the norm. If when you radio to the hospital, if their vital signs are fine, you can give them. Well, actually, I won't even say that because I don't want to start a bad habit. Always give your vital signs to the ER, whether they're in normal limits or not. We'll just say that because I don't want to steer you guys wrong. All right, we're going to take a quick break. I know it's early, but like I said, tonight's going to be a short night. Um, we're about to get into the complications and problems that you may run into with chest injuries, and um, this is one of the last topics we're going to go over. So take a 10-minute break. Be back at 5 minutes till, and we'll continue on. Yeah, man, I love it. I've used it in the past myself. I've used a couple other ones too, but that one's fantastic. And as you look, there's a test banks for every level. So you can keep that. And if you decide to go on to AEMT or paramedic down the road, it's great for that as well. Yeah, I think so. But the good thing is if you've paid into it, then when they add new questions, you automatically get them. It just gives you full access to their test bank. All right, let's get back to it. Like I said, we're just going to go over some injuries, different things that can happen to the chest. There's surprisingly quite a few of them, but it's not as bad as some other chapters are. We should be done here in the next 20 slides or so. All right, so complications. First thing on the list is pneumothorax. This is one of the most life-threatening. That's why we put this at the first. This happens because our patient, not we, patient has a collapsed lung. Now, there's two problems with this. First of all, a collapsed lung means that lung is no longer going to be able to supply oxygen to the body. The other problem, though, is because the chest is still trying to expand like normal, the diaphragm still contracts like normal. So if there's a collapsed lung, if there's a lung with a hole in it, you're still going to be, based on how we breathe, how we ventilate air, it's still going to be coming in to that lung and then just getting loose into the chest cavity. So every breath your patient takes with a collapsed lung, they're only going to get half the effect of it. That other half is going to get into the chest wall and it's going to stay there. And it's going to eventually start to put pressure on the heart, put pressure on the good lung, and everything is going to shift as your patient gets worse and worse. And you will see it because their trachea that runs down the midline of their neck is going to start to push to the side. We call that tracheal deviation. When that happens, the trachea is pointing toward the good lung. All right, so think about that. If you take a breath with a lung with a hole in it, if it's, let's say it's your right lung is popped, you take a breath, air going to the right lung gets loosened to that side of the chest cavity and it stays there because it can't get back out. As you take another breath, it adds more air and then more air, and it starts to push. It pushes everything over, which drags your trachea across your neck. It's a really creepy thing to see. Hopefully you guys, I'm not gonna say hopefully you don't see it because then you never really get the experience of taking care of it. But um, usually when you see that, that's a late sign. That's a real big pucker moment because we can't do needle decompressions as EMTs. So if you're there without a paramedic, there's major problems with that because they're not going to be able to breathe. The more pressure it puts on that good lung, the less that lung's going to be able to work. And there's nothing you can do. You can't bag them back from that, unfortunately, because you're just going to make the problem worse. So you really, really need a paramedic there. Um, Blood passing through the collapsed portion of the lung is not oxygenated, like we were talking about. If you are trying to assess your patient's breath sounds, if I tell you that you hear good sounds on one side, but your sounds are either diminished or absent on the other side, I want you to associate that with a collapsed lung. That means that there's no airflow that you can hear because the lung is not inflating properly. Doesn't mean it's not moving there, like we were just talking about, but you won't be able to hear it like normal. All right, so here's an example. You have your parietal pleura. That's basically the chest wall side of the lung cavity. The lung itself is going to condense down, and as you can see here, the wound site, that's where the hole's at. So when you breathe, air goes into that lung, but it can't inflate. It just comes out through the hole and gets stuck in the chest cavity. And as it expands, it starts to shove everything over. The heart gets pushed, the good lung gets pushed. All your vessels are going to get drug over with it, that kind of thing. An open chest wound is often called a pneumothorax, I'm sorry, an open pneumo or a sucking chest wound. So this is one of those injuries that I want you guys to find early on, particularly in the B portion of your primary. This is one of the two injuries. When you get to breathing in your primary, cut off the shirt or remove the shirt or whatever, and you're looking for two injuries. This one is being one of them. It's a sucking chest wound. If somebody's been shot and they have not just a puncture in their lung, but also a puncture leading to the outside of the body, um, every time they go to try to take a breath and their chest wall expands, that hole is going to suck air in as well as their airway. So they're getting air into their chest that much faster. Um, and you can actually have this without the lung being collapsed. So that's one of the things about an open chest wound, thankfully, is that we can fix these if we get them early enough. That's why I want you to find them in your primary. All right, because if let's say they got stabbed or even shot and it went in a trajectory that opened a hole to the chest, but it didn't actually puncture the lung. Um, when they take a breath, air is going to get into the chest cavity from that hole, but the lung is still intact. So the faster we plug that hole up, the faster their breathing is going to be fine. or at least it won't get any worse than it already is. So if you see this, and we'll go over to boot camp, but the very first thing you do, because you want to get this fixed as fast as possible. So take your hand, which should have a glove on it, and immediately cover that hole. Just plop your hand on it. All right. Now, congratulations, you have fixed the open chest wound. However, you're kind of stuck there unless you put something else in its place. So we make what's called occlusive dressings, and you can make these out of pretty much anything that's non-permeable. Credit cards work. We always teach to use your military IDs in the military, but you can use their driver's license. Some ambulance companies will have occlusive dressings that they actually purchased and they're in your bag. Any kind of saran wrap will work. Anything of that sort that air can't get through. So once you get it prepped, you're going to move your hand, put the saran wrap or the card down or whatever, and then you're going to tape it up on the side so that it stays in place. Now, we used to say tape 3 sides and leave one corner untaped so that you could peel it and burp it if you needed to. They've done away with that. Now they just say tape all 4 sides. And then some, like if you do happen to have occlusive dressings in your bag, a lot of them come with the flutter valve that acts for the burp itself. So if that's what you've got, then definitely seal all 4 sides because you don't need to lift anything. But if you have an open chest wound, make sure you look all the way around their chest for an exit wound. Because assume that they got shot, for example. If the bullet goes through and through and you close one sucking chest wound, but you fail to find and close the other one, they're just going to continue to pull air through the other side. It really does. That makes your first occlusive dressing useless. If you put an occlusive dressing on them and you see that they're starting to trend down that collapsed lung pneumothorax that we looked at, where they're getting worse, even though you put an occlusive dressing there, it should tell you that either they have a collapsed lung, or B, there is an exit wound somewhere that you missed. So do a quick search, maybe a more inclusive search or whatever, try to see if you can find it. All right, so there's your example. And in this case, as you can see, the lung is actually fine. It's the cavity that's got the hole in it. But as that fills, it starts to put pressure on that lung, and you wind up with the same problem. It's air in the chest. A simple pneumothorax does not result in major changes in the patient's cardiac physiology. This is commonly the result of blunt trauma that results in fractured ribs. So you'll have decreased breath sounds associated with significant lung collapse. In other words, basically you just may have punctured a lung, but that's it. Signs and symptoms include dyspnea, increased work of breathing, and an increased respiratory rate. Oh, too far. Tachypnea and accessory muscle use, where they're trying harder to take a breath because for whatever reason they can't get a good one. You're going to see a couple of things like unequal rise and fall of the chest. That kind of thing is going to start to happen because the chest actually rises as the lungs expand. If one lung's not able to expand, then that side of the chest is not going to rise. So a crackling sensation felt on palpation of the skin, which is subcutaneous emphysema, that's air in the skin. If you're pressing on their chest and it feels like you're popping small air bubbles, that tells you that you're getting air in places that it's not supposed to get there. And if their lung is intact and they have no holes, they wouldn't have air there. Some late findings you may find: decreased breath sounds on the injured side. So at that point, that side's lung is pretty well shot completely down. Lethargy, they're getting tired because they're not getting enough oxygen. And cyanosis is the visible sign that they're not getting enough oxygen. Be vigilant. We can't fix these. Simple pneumos, tension pneumos, open ones. Well, we can fix open pneumos, but we can't bring them back once it gets bad enough. So the faster you find these, the faster you do what little bit we can as an EMT, the better off your patient's going to be. You're going to buy them time. If it is bad enough that they need an actual intervention to get them back, say you got there late, you didn't find the open chest wound until they were already starting to get those bad signs like the tracheal deviation, then definitely get a paramedic out there as quick as possible because they can do needle decompressions and release some of that air that's built up in the chest. For your tension pneumothorax, this results from ongoing air accumulation in the pleural space. The air gradually increases the pressure in the chest. This will cause a complete collapse of the unaffected lung if it gets bad enough. It's just going to keep pushing and pushing and pushing until finally the other lung just can't do it anymore. It'll pop, or it won't inflate at all. Your mediastinum is pushed into the opposite pleural cavity. That's what causes your tracheal deviation. So like we were talking about there. Blood can't return through the vena cava because they're putting pressure on that particular vessel of the heart. All that air is in a place it shouldn't be, and everything else that is in that space no longer has the space it needs to work. So you're going to wind up with decreased cardiac output. So now you've gone from a respiratory issue to a cardiac issue, and a lot of times that's going to kill your patient. Common signs and symptoms include chest pain, tachycardia, marked respiratory distress, absent or severely decreased lung sounds on the affected side, low blood pressure, altered mental status, JVD, cyanosis, and tracheal deviation. As you can see here, all that pressure on the affected side is shoving everything over. If this is what you're dealing with, the needle decompression is critical. So at this point, we definitely, you either need a paramedic or a priest at this point, because they're probably not going to come back. Hopefully you get the paramedic there. And the sad thing is too, is even in school for paramedics, they're taught, needle decompressions will fix this and everything. And yeah, it will. But if anybody's ever done these, if you guys that are in the military have ever done these in the real world or whatever, or if your trainer has ever done it in the real world, which a lot of times they haven't, but you find out that the needle decompressions are not fast fixes. In fact, a lot of times they can still accumulate air faster than the needle is getting rid of it. So hopefully your paramedic brings multiple needles and they can just put a bunch in there. So every one they put in is that much more air getting out at one time. All right, hemothorax. So hemo meaning blood, thorax meaning the chest. Hemothorax is blood in the chest, blood in the pleural cavity. Can be caused a lot of times by blunt trauma or shearing of one of the main veins. So like the vena cava gets sheared or the aorta gets sheared, that will cause it. Some common signs and symptoms include shock, because we're dealing with blood no longer in the system. There may not be any obvious external signs of bleeding because it's just chilling out in the chest cavity. You're not actually seeing it come out of the body. Decreased breath sounds on the affected side. Pre-hospital treatment includes breathing. Pre-hospital treatment is pretty much the same as a pneumo. We can't really do anything about it. There's a couple of paramedic level maneuvers, but as an EMT, we can't control it. This is internal bleeding. We can't stop the bleed. So pretty much just diesel, get them to the hospital as quick as you can. Hopefully a paramedic can be there. You could technically have a paramedic could put needle decompressions into a hemothorax, but the problem is they're going to be fighting blood clots. As the blood's passing through the needle, a lot of times it'll get clogged up and it winds up not helping either. So the best bet is just get them to a hospital. They definitely need a major surgery at this point, like a chest tube or something along those lines. And then a hemopneumo, just so you know the term. Pneumo means air, so the pneumothorax was air in the chest. Hemo means blood, so that's blood in the chest. So if you have both, you have a hemopneumothorax. For your cardiac tamponades, some lucky paramedics around the country get to actually do this stuff in the field, but thankfully I'm not one of them. This is not something that I really would like to do. I'm happy that a lot of paramedics don't get to do this, but depending on how remote you are, it may be a necessity. Cardiac tamponade is where the fluid builds up around the heart itself. So instead of being around the lungs, like we've been talking about, this is where fluid builds up in the actual pericardial sac, stopping the heart from being able to beat properly. If it fills up, the heart can't beat because it no longer has the room to do so. As EMTs, there's absolutely nothing we can do about it. All we can do is try to identify it and drive faster. There's not even really anything that we can do to slow this down, because again, we're dealing with fluid, not air. So proper ventilatory support, If you deal with this in a trauma situation, I want you to kind of think of it from a CHF standpoint. Even though it's not congestive heart failure, your patient's going to mimic a lot of the signs of CHF minus the swelling in the hands and the feet, because it's not a circulatory issue. It's the blood in the chest, the blood around the heart issue, congestive in that sense. Um, some signs and symptoms that you're going to deal with. We have what's called Beck's triad. Is that on? Yeah, okay. So well, that's all it says. Anyway, Beck's triad is a set of 3 signs and symptoms that always typically points to a cardiac tamponade. This is distended or engorged jugular vein. So you're going to see that because like I said, when the heart can't beat properly, the blood trying to get into it starts to back up. So you'll have those increased engorged jugular veins on both sides. You'll have a narrowing pulse pressure. If you think about what your blood pressure does, your bottom number is your diastolic. That's the pressure that's in the veins at all times. If your heart can beat normally, your systolic will jump pretty far above your diastolic, 30 points, 40 points, whatever. As that number, if they have a tamponade, as it gets worse, the heart doesn't have the room to beat as forcefully. So that systolic, that top number is going to start to come down. The pressure in the veins is going to stay the same, or it may even rise. It just depends, but it's not going to drop with the systolic. The numbers are going to start to get closer together. And when the tamponade is complete and the heart can't function at all anymore, then your blood pressure is basically going to be the same number. You won't be able to pick up a systolic blood pressure. So you'll have that problem, and then you'll have muffled heart tones. If you're listening for the heartbeat, it'll be muffled because there's a big barrier of fluid that's surrounding the heart between it and your stethoscope. Altered mental status can happen due to decreased blood flow to the brain. So for pre-hospital treatment, just support ventilations is the best you can do, and get them to a hospital because they need surgery, either a chest tube or something of the sort. They can do pericardiocentesis is what the typical surgical maneuver is. Some, like I said, some select few systems in the country will allow a paramedic to do it, but it's pretty rare. You're more likely to not have that in your protocols than you are to actually see it. I don't know of anybody in the South that does it. I want to say like Maryland or Virginia, they can do it. Alaska can do it because if they couldn't, nobody would survive those kind of injuries. They're so far from a hospital. Rib fractures, these are common. I mean, again, like I said, all of us down there in the South that are Saints fans, your star quarterback is suffering from this right now, particularly older people whose bones are brittle. Poor Breeze. A fracture of one of the upper 4 ribs is a sign of a very substantial MOI. Those ribs are small, they're close together, they tend to take hits really, really well. The lower you get in the rib cage, the more likely you are to find those breaks. But if it happens in the upper 4, that's a pretty big impact. And keep in mind, proximity to the neck means that impact probably caused a whipping effect that could have caused some cervical damage. So if you're dealing with a patient with this, consider C-spine. A fractured rib may lacerate the surface of the lung, causing a pneumothorax, tension pneumothorax, or any of the ones we talked about. It could be blood, it could just be air, it could be both. I fractured 2 in one of my floating ribs. Ooh. Well, I would say lucky you that they were floating ribs and that far down. But yeah, no, I imagine that is extremely excruciatingly painful. I've been fortunate enough never to break a bone outside of a couple of ankle sprains. Um, yeah, that sucks. What'd you do, if you don't mind me asking? Beat somebody's ass in a bar? Oh man, come on, you gotta come up with a cool story at least. Every broken bone needs a cool story, even if it's bogus. All right, anyway, back on this. So signs and symptoms, localized tenderness and pain when breathing, because every time you try to expand your chest wall, it's going to be pulling on those broken bones, and you will feel it. Rapid shallow respirations, typically because of the pain, and the patient holds the affected portion of the rib cage. That's a reflex. Anytime, because think about it. Our bodies physiologically know that the ribs are there to protect the internal organs. If we ever have an evisceration of our abdomen where we might be losing organs, or if we ever break our rib cage, the natural response is to bring our arms in because that's extra protection for an otherwise compromised area of the body. So if you see your patient doing that, that's a good sign that they're not faking, or not even thinking about faking, but that's a good sign that they probably did really break a bone. Um, that's just it's a natural tendency. All right, flail chest. This is the other injury that I want you to find in your primary. All right, so remember everything we're going over as far as like decab BTLS stuff, I don't really concern myself with during the ABCs, but when you get to breathing, I want you to find your sucking chest wounds and the flail segment. As you can see in this picture, this is a blunt force injury, and it's something that completely breaks a section of 3 ribs in 3 or more places. This 3-piece section of ribs is completely separated from the rib cage. So when the chest expands and the chest wall expands out, those 3 ribs in this picture, they can't expand with the chest because they're no longer connected, so they're not getting drug out. And if you think about what happens, like I said, when we expand our chest cavity, the pressure inside the chest wall drops, which means that that section of ribs is going to fall in because the pressure of the chest is no longer there to hold it out. So you wind up getting this seesaw effect where your rib cage expands out and the flail segment drops down. They call it paradoxical motion, and it's where that section of the rib cage is moving. It's just moving opposite the rest of the chest wall. The VA said you were fine. Wow, just a flesh wound. Walk it off. All right. Yeah, typically I know, right? Hey, at least they gave you a verdict. They didn't tell you to come back in 6 months when the wait was over. Um, I've had the VA tell people that went there for mental health reasons that they couldn't be seen until like the following November, which was a year and a half later. And then they wonder why mental health is such a crappy thing in the military. It's because it's stupid. So I mean, it doesn't surprise me that it's any different for trauma, to be honest with you. I'll say this, politics aside, I don't get into politics. This is something that I did like that President Trump did when he was in his office, and it really doesn't matter what your politics are because this was a very good move. Um, he made it to where if you go to the VA and they tell you that you've got more than, I think just like a couple of days, especially for mental health, if you've got more than a couple of days of a wait, they're supposed to give you a voucher that you can take to anybody, regardless of whether they're in network or out of network, get seen for free, and that voucher is for them to bill the VA, and the VA just pays them, and it's completely separate from your insurance, um, which is fantastic. I mean, that should hopefully alleviate a lot of issues that we see with the military community and retirees and all that. So hopefully, a lot of those long waits that we have will go away. Anyway, back to the class. Your flail chest, that section of ribs is completely detached. So when you inhale and your rib cage expands out, um, that section is going to collapse down. It's everywhere also. Yeah, no, it is. I know it's not just the military. But speaking with the VA directly, the VA is very underfunded for the size of the population that they're expected to take care of. The military, when you consider the retirees and everybody that's gotten out but maintains their benefits, the military itself is huge. Separated military is exponentially huge, larger than that. So yeah, it's everywhere, but the VA itself is just specifically overrun. It could be. I mean, I know the VA up here I mean, it's almost lines out the door. I've never seen the bottom floor not completely packed out. And the only thing down there is pharmacy and the welcome desk. But pre-hospital treatment, maintain their airway. We used to say that you needed to put a bulky dressing here and it was supposed to stabilize the flail segment. They found out that it really doesn't work like we expected it to. So you don't have to. Some curriculums are now saying that you just note it and move on. But I still want you to look for it because those broken ribs can puncture the lung. And even though they're probably not going to talk about it here, if y'all have ever been CPR certified back before 2015, um, they had a different, the CPR training had a different way of telling you where to put your hands for the compressions, and they always specified, don't put it on the xiphoid process, and fine for people that are in the medical field and know what that is, but you're trying to teach somebody that works at McDonald's not to do that, and they're going to look at you with these glossed over eyes and be like, "What's the xiphoid process?" Um, if you look at this picture, that little bitty bony tip at the bottom of the sternum, that is your xiphoid process. We've long since learned not to do compressions on that, but if they ever get hit there and it fractures that bone can go anywhere, and it can puncture there. It's right at the level of their diaphragm. So it can puncture the diaphragm. It can puncture the stomach. If it goes above the diaphragm, it can puncture the pericardial sac. It can get into the lungs. All that stuff. It's a very easy to break bone, and it's sharp when it does break off. So very dangerous. Just a little tangent. Keep that in the back of your mind as you go into your careers. So your pre-hospital treatment for the flail segment as they teach it now is going to basically just be maintain your airway, provide respiratory support if needed, so bag them if you need to, give them oxygen, and perform ongoing assessments for possible pneumo or other respiratory complications. You're just worried about whether or not those ribs broke through the lungs or any of that sort. If you feel like you have the time, first of all, and if you think it will help, you can do some efforts to stabilize it. You can go back and do it later, maybe in your secondary assessment. So if you do a bulky dressing, we're not gonna knock you for that. You just don't have to. If you decide to wrap them with a compression bandage, like an ACE bandage or something, and try to hope that does it, fine. But just make sure that you don't do anything that makes it even harder for them to breathe. If they're already going to have a hard time making their chest expand, if you strap a ACE bandage around them real tight to try to stabilize that one flail segment, but now you've made it harder for them to expand their chest, it actually did more harm than good. And that's kind of been the reason why they got away from other interventions that they used to teach. Treatment may also include positive pressure ventilation with the bag valve mask, so you may need to bag them. Restricting chest wall movement is no longer recommended. And then a flail chest may indicate serious internal damage and possible spinal injury again, because they got hit that hard that it took a complete section of ribs, multiple ribs, and broke them off completely from the chest. If it was one rib, that would take, I don't know, X amount of energy. But to break 3 ribs, that takes triple the amount of energy to do the same damage. So that's a massive, massive injury. That would be like taking a sledgehammer full swing into the ribs. All right, okay, we're in the home stretch, guys. This is almost it. So for your other chest injuries, we have pulmonary contusions. Should always be suspected in a patient with a flail chest. So if you see the flail chest, you should expect the pulmonary contusion. Pulmonary alveoli become filled with blood and the fluid accumulates in the injured area, leaving the patient hypoxic. This is basically a bruised lung. But the problem is, unfortunately, it's not like a bruise in the skin where it's just like, well, that's inconvenient. A bruised lung, the area that's got that blood, those alveoli can no longer do their job as oxygen transport because they're flooded out with blood. And we can't do anything about that in the field. If somebody gets a big enough pulmonary contusion, they'll suffocate. Hopefully that's not the case, but if you worry about a contusion, get them to a hospital because a surgeon can get in and try to get the blood out. Give them oxygen. So if 20% of a lung goes down for a contusion, they basically lost 20% of their oxygen transport. So if we give them more oxygen, hopefully the other 80% will make up for it. Sternal fractures require a significant amount of force. The sternum, it's movable, it's large, and it can take a big hit. If you fracture that, you got slammed in the chest. That's 70 miles an hour under the steering wheel kind of hit. These create an increased index of suspicion for injuries to underlying organs, and because you're front and center, it can be any one of them. It can be either lung, it could be the heart, most likely the heart. If you get hit that hard, especially if you're the one that's in motion, Say like I said, 70 miles an hour into a tree and you're not buckled up and your airbag for whatever reason doesn't deploy. So you smack the steering wheel at 70 miles an hour. That means your heart hit the inside of your rib cage at 70 miles an hour. It very likely will have sheared some, if not completely, off of your vessels, and then you're going to have a massive bleeding from there. So your sternal fracture, if you encounter this, just be aware that it's probably the least of your concerns overall. They're probably going to have some serious internal injuries. Is it true that the flail chest is somewhat common with bull riders? Hmm. I'm going to say yes. The most, I don't know if I would say common, but it makes sense. So the only flail segments that I've ever worked at a rodeo were because the guy fell off and the bull, still bucking, came down and his hoof caught the man in the rib cage and snapped his ribs right there. Full weight of the bull, all that weight on just the surface area of a hoof. Um, of course, I'm from a small town, so it's not like we worked a lot of those. I don't know, grand scheme of things, rodeo wide, probably, yeah, it could be pretty common. The hole in my heart ripped more in an accident when I was younger. That sucks. Did they fix it? I mean, you're still with us, so it can't be that bad. But do you still have any lasting effects from that, Tiffany? Well, that sucks. But yeah, Tamara, I mean that makes sense. And I don't know about the vest. I mean, I'm not a rodeo guru by any means. Um, you that's good. Somebody, okay, so then yeah, I'll defer to you for that one then. So a vest will stop the damage. What kind of a vest is it? Is it just like a flak, well, not a flak vest, but a reinforced Kevlar? Okay, biker proof. That's new. Oh, bulletproof. That makes more sense. All right, well, cool. So now I'm learning something. All right, so clavicle fractures. These are covered under skeletal injuries. We talked about them before. Your clavicle is just your shoulder bone. It's on the anterior side. Um, these are not easy to break because of their location, but they are common breaks, especially for kids, football players, people that put any kind of impact into their shoulders. But you almost have to be in a certain condition to hit that bone, is the thing. So they're not common overall, but for people that do any kind of impact in that area, it can be pretty common. The bone's not that big. Significant damage or disruption to the large neurovascular bundle that the clavicle protects is possible. And think about that. Those the neuro bundles that are that high up are pretty important because they're closer to the brain. So if anything damages there, they could lose some serious function. If you break your clavicle, you can suspect upper rib fractures as well because they're very, very, very close together. Be alert to possible signs of pneumothorax development. Traumatic asphyxia. This is characterized by extended neck veins. I see if no, this person's overweight. It's really can't see it in this picture. But distended neck veins, cyanosis in the neck and the eye and the face, and then hemorrhage into the sclera of the eye. So if her eyes were open, they would be, to say bloodshot would be an understatement. It would look like the eyeball was just full of blood. This involves sudden compression of the chest, which produces a rapid increase in pressure within the chest. So crushing chest injuries, if somebody gets something like an engine block, which is probably what happened to this person. I can't really tell from the markings on the chest, but a buddy of mine when I was in college, he was working at the mechanic shop in the class at the college to get his education in vehicle mechanics and everything. And he was under a car working on somebody because the way that they did it was for experience. You could bring your vehicle there; they would work on it for cheap because you're taking your destiny in your own hands basically to have somebody who doesn't really know what they're doing completely work on your vehicle. But This guy had this my friend. He had a vehicle propped up. He was underneath it. He was doing something, and then the jacks came out. Vehicle crashed down on him, and he survived, but it messed him up pretty bad. All that weight hitting him in the chest, it just think one massive, half ton, not maybe not half ton, but quarter ton chest compression of CPR. All that blood is just going to get shoved very, very violently out, either up to your head, which is what happens in this picture, and also down toward your pelvis, which normally is not that. That's not the life threat. The life threat would be what comes up, but in this case, that's what happened. If you deal with this, you're going to provide ventilatory support, try to get as much oxygen into them as you can. Just understand that the blood in the pulmonary veins and pulmonary arteries probably shot into the lungs, so you're probably going to definitely have to bag this person. And then monitor their vital signs, immediate transport, they definitely need a surgery. For blunt myocardial injury, this is bruising of the heart muscle itself. Um, Knowing what bruising is, that's blood accumulating inside of the muscle. You can imagine that if the heart muscle gets engorged with blood where it doesn't belong, it can't compress to do a heartbeat because the muscle is full of blood. Blunt trauma may injure the heart itself, making it unable to maintain adequate blood pressure. Some signs and symptoms are going to be an irregular pulse rate, VTAC, which is a shockable rhythm. I'm sorry, VTAC and VFib are uncommon. So you're really not going to, I guess you're not going to see that. I always was under the impression that you would. Patient may complain of chest pain and discomfort, similar to cardiac symptoms, but it's not going to be anything that you would typically need an AED for. Suspect myocardial contusion in all cases of severe blunt injury to the chest. And if this is what you're dealing with, you're going to monitor the patient's pulse carefully. I would say monitor the patient's pulse constantly. Note any changes in the blood pressure and provide supplemental oxygen transport immediately. Again, it's like I said at the beginning of the module, the only thing that fixes trauma is surgery. And we can't do that in the field, especially not as EMTs. So a lot of what we do is stabilization, monitoring and fixing their ABCs and getting them to a hospital as quick as we can so that they can get that surgery. Commotio cordis. This is a blunt chest injury caused by a sudden direct blow to the chest that occurs only during the critical portion of the person's heartbeat. Without getting too far into the weeds on this, you're basically hitting somebody in the chest at just the right moment, and it's a fraction of a second to send them directly into cardiac arrest. It's highly uncommon, but it is possible. If you ever remember old TV shows where they're doing, hold on a second, they're like, breathe, damn it, and they hit the person in the chest, and all of a sudden the guy just comes up and he's, oh my God, what happened? It's basically the same thing. It's just on the other side of the spectrum. So it's that supposedly it's that one hit that you can get it timed just right, catch the heart, and its electrical vulnerability. There's a little spot if you learn how to read an EKG. There's one part between two different waves that if you impact the heart either with electricity or with a mechanical blow at that particular moment, it screws everything up. That's what this is. And if they're if they're already in a shockable rhythm in the time before AEDs, they used to teach what do they call them? Pericardial thumps, I think is what it was. This is before my time, but I remember learning about it, where they just beat the chest one real good time, real hard, just hoping that they can time it, and then they'll wait a second and then they'll do it again. That's it. Yeah, the pericardial thump. If you it used to, I mean, it was they were. I say it used to. It's potentially possible, possible enough that they used to teach it. That's why it's got its name and all that stuff. But if this is what you're dealing with, usually in today's world, an AED will bring them out. Because what you did is you put them into VFib. You were taught the pericardial thump. Wow. Yeah, they got rid of it mainly because they figured out what was causing it. And AED, that's a shockable rhythm. So you strap an AED to them, pop them one time, and it usually brings them out. And you don't have to worry about the timing of it. This phenomena has been documented to have occurred after patients were struck with softballs, baseballs, bats, snowballs, snowballs, fists, and kicks. Resulting ventricular fibrillation responds positively to defib, like I was saying, within the first 2 minutes. If you don't get it on there very fast, they're going to descend into full-blown cardiac arrest, and then you're going to be pumping on the chest. This is more commonly associated with sports-related injuries, and it's funny because we actually had questions on this at the paramedic level. Had a couple of scenario questions where it was like, you show up to a baseball field where the pitcher's laying on the ground unconscious without a pulse, and the the coach reports that he was struck in the chest with a line drive. And this is exactly what they wanted you to think about. So you may see this on the registry as well. Just know that this is the cool thing about this is if you see this in the real world, you can be like, I can fix this and go get the AED. All right, laceration of the great vessels. This is the last thing we're going to talk about tonight. This may be accompanied by massive, rapidly fatal hemorrhage. So I want you to think about this on the level of the aortic aneurysms that we talked about in the past. If you sever the vena cava at the point where it's at the heart, that's the biggest that vein's going to get. It's just as big as the aorta. Or if you shear the aorta itself, obviously, like I said, then you're going to lose blood to the level that will kill your patient just about as fast as it takes you to realize that they've got that problem. The great vessels include your superior and inferior vena cava, the pulmonary arteries, 4 main pulmonary veins, and your aorta. Pre-hospital treatment, CPR. They're going to be out of it that fast. Where if you're going to do anything at all for them, it's CPR, and it's a lost cause because all their blood is going to come out. So, but do something. CPR, give them some oxygen. Immediately transport and remain alert to signs and symptoms of shock. If you're lucky enough that it's a small shear, you might actually have a few minutes. So don't just write them off. But I've not seen anybody make it more than 30 seconds with one of these. And unless you're in the parking lot of the hospital, I don't see them surviving. But that's it. Any questions on tonight's lecture? Like I said, short and sweet. The biggest thing about chest injuries is knowing about the rib breaks and what they can do, and then keeping in mind the organs that are underneath those ribs that you have to worry about. So I want you to think airway and breathing, circulation, pulmonary and cardiac. That's your big concern with your chest injuries. And you're going to get a lot of practice with this when we go to the boot camp. I'll be sure to give you guys scenarios that make you question these things and learn how I want you to do your assessments through them and stuff like that. Your pin for the night is going to be Bravo Charlie 29 C. So Bravo Charlie 29 Charlie. If there's no questions, we'll call it a night, and I'll see you guys on Thursday. Today's Tuesday. Yeah, so Thursday. I'll see you on Thursday. It all runs together after a while. So y'all have a great night, and take it easy.